Okay guys, Timmy coming at you here today. And today what I'm going to do is I'm going to go over hypovolemic shock. So again, understanding a little bit about the cardiovascular system is critical in terms of understanding it. And what I'm going to do is I'm going to kind of combine hypovolemic and hemorrhagic shock. So if you think about it, hypovolemic shock is the broad class, and underneath it, a subclass of hypovolemic shock would be hemorrhagic shock, and that's basically due to blood loss. Now, a couple of things, right? And that's why I had you watch those prep videos prior to looking at shock. If you recall, right, cardiac output is heart rate times stroke volume, right? And stroke volume, again, is essentially the amount of blood pumped per beat. So stroke volume is blood pump per beat, right? So what's a normal heart rate? Normal heart rate is about 70 beats per minute. So that's the number of times the SA node fires. And the normal stroke volume in a resting person, average size adult, is about 70 cc's per beat. So the beats cancel out and you're left with approximately 5,000 cc's per minute, or 5 liters per minute. So the average adult pumps about 5 liters per minute. Now, one of the things that determines how much blood is pumped by the heart, and specifically the right heart, is the amount of venous blood that's returned to it. And remember that the circulatory system is a closed system, meaning blood's not sloshing around. It's floating, or, it's flowing around in arteries and veins. And a couple of things you need to know and need to remember about veins, right? There's no pressure. So, and that's why I asked you to watch that video. There's no pressure in the venous system, and the veins store extra blood, right? So where do you store a lot of extra venous blood? You store it in your legs, right? So there's no pressure, and you store extra venous blood in your legs. And you should know why I'm telling you that. All right? So I'm going to come back to this in a minute, but let's just give you an overview real quick. All right? So hypovolemic shock, right? By definition, just like in all shocks, right? All shocks by definition, sure, the mean arterial pressure is less than 60, right? So if your mean arterial pressure is less than 60, then you're having a difficult time perfusing your brain and vital organs, right? And that's usually due to like a 15 to 30% decrease in circulating blood volume. Now, for whatever reason, right? So if you cut yourself and you're bleeding your own blood, right? Sweating, excessive vomiting or diarrhea, or severe burns, right? Now remember that the skin holds on the fluid. So if you have burns, that's why, burns, you lose fluid, it weeps, right? If you ever had a blister, you're gonna lose that fluid. So imagine heavy duty burns all over your body where a good percentage of your skin is lost to that burn. You're gonna be losing a lot of volume. And people with severe burns, typically over 50, 60, 70% of their body, the reason they die within the first 24 hours is due to hypovolemic shock. They just lose so much fluid and it can't be replaced. And then again, excessive sweating with no fluid replacement, or excessive vomiting or diarrhea. But the most common cause of hypovolemic shock is either internal or external bleeding. So let's look. Now again, I'm going to try to explain these to you. Now watch. You're going to get skin that's going to be pale, cool, and clammy. And the reason for that is when you're losing blood, the body does stuff that makes sense, right? So you got this autonomic nervous system called the sympathetic nervous system. That's the fight or flight, right? And then you got the hormone of the sympathetic nervous system. You got our buddy epinephrine, right? So when you're bleeding your own blood, that's stressful to the body. So what do you want to do? You want to maintain blood flow to the core. So the sympathetic nervous system is going to cut off blood flow to the non-essential parts of your body, the skin and the extremities, right? So the sympathetic nervous system is going to cause the muscular wall of those arteries to massively constrict. Boom. And blood always takes the path of least resistance. So you're not going to be sending blood to your extremities and skin. And that explains why it's cold, pale, clammy. Poor capillary refill time, you push on somebody's nail bed, because not a lot of blood flows going there. When you push it away, it's going to take a long time for it to come back. Now, the rapid shallow breathing, again, that's a result of the sympathetic stimulation and the drop in O2 saturation of the blood. When there's a drop in O2 saturation of the blood, in the arch of the aorta and the carotid arteries, you have these things called carotid, yeah, I can spell that, bodies. Basically, these things detect drops in oxygen in the blood. So red blood cells, plasma carry oxygen. So if there's a drop in oxygen, when that left ventricle is pumping that blood, there's going to be less oxygen in it. And that's going to be detected by these little chemoreceptors, these little carotid bodies. And that's going to feed back on the medulla and tell you to start breathing faster and deeper, right? Try to compensate for that. Now, low systolic blood pressure and high heart rate, right? I explained that. Now, look, again, we talked about cardiac output, but remember, the amount of blood that's pumped by the right side of the heart is determined by the amount of venous return that comes back to it, right? And that is a big fancy word. Venous return is called preload on the heart. So if you're bleeding your own blood, you're going to have less extra blood stored in your veins. So what's going to happen to the amount of venous return? Well, that's going to drop. So preload drops. And preload really is essentially, it determines the stretch of the heart. And if you watch a little video on Starling's law on venous return, if you have less stretch of the heart, right, because you have less venous return coming back to it, that's going to decrease the stretch of the heart, like kind of like a rubber band. And if you decrease the stretch, you decrease the force of contraction of the heart. And if you decrease the force of contraction, how hard that heart contracts, you're going to decrease the systolic blood pressure. You're also going to decrease the stroke volume, meaning the amount of blood ejected with each beat. Because there's less blood in it, it's not going to contract as hard. It's not going to send extra blood out. It can't because it's not stretched as much. And you also learned that the right heart and the left side of the heart, right side, left side, pump the exact same amount of blood. So if you're bleeding your own blood or you've lost blood volume for those reasons we just discussed, then your blood volume drops. That means venous return or preload drops. If preload drops, then the right heart is stretched less. The force of contraction will be less. The amount of blood ejected with each beat and the pressure with which that blood is ejected to the lungs will be less. And because the amount of blood pumped by the left heart is determined by the amount of blood pumped by the right heart, now less blood's going to come back to the left heart, and the same thing is going to happen. Less blood, decreased stretch, decreased force of contraction, decreased systolic blood pressure, decreased stroke volume, right? So if you decrease stroke volume, then you have to increase the heart rate to try to maintain cardiac output. So that's why the heart rate is going to be high. All right? So blood pressure low, heart rate high, and that's a compensatory mechanism. The activation of the sympathetic nervous system is compensatory. You're trying to maintain blood flow to that brain and vital organs. Now, if they're conscious, right, they're going to be scared. Why? They're bleeding. That's scary. You should write that down. Right? They're scared and they're anxious, and that's due to the activation of the sympathetic nervous system. They're going to be thirsty too, because if you watch a little two curved lines in a circle, the goal of the body is to maintain blood volume, right? And your hypothalamus controls thirst. So capillary fluid pressure, which is really determined by your systolic blood pressure, that's going to drop. So there's going to come a point where the pressure in the capillary is going to be lower. So fluid from the interstitial space is going to get pushed into the capillary in an attempt to maintain blood volume. And when you withdraw fluid from the hypothalamus, that's going to trigger thirst. The other thing is that this is happening all over the body. So all the cells are exposed to this low capillary fluid pressure in the blood because you're losing blood volume and your blood pressure is dropping. So all of that fluid from your tissues is going to try to get pushed into the capillary and try to maintain that blood volume. So you're going to have dry mouth and really dry mucous membranes and decrease urine output. And again, this is important. One of the things that determines urine output is systolic blood pressure. And when you have a drop in systolic blood pressure, you also have a drop in systolic blood pressure in your kidneys. And if your systolic blood pressure drops in your kidneys, then your kidneys will decrease urine output, right? It wouldn't make sense to be peeing if you're bleeding. Okay, look, I'm bleeding on my blood. I really got to take a leak. That wouldn't make sense. And the other thing, if you watch the stages of shock, that's why I had you watch them first, is with that drop in systolic blood pressure, that's going to activate renin, angiotensin, aldosterone system. And that's going to increase the amount of sodium in your blood to try to increase the amount of water in your blood, and that's going to decrease urine output. And you need a urine output of at least 30 cc's per hour. And if you can get that, then you're maintaining adequate blood flow to the kidney, right? So again, all of these little things make sense. And if you understand what's going on, at least at a basic level, right, then you should be able to understand why you get these signs and symptoms. The low core body temperature, remember your cardiovascular system is the radiator of your body. It can hold on to heat or it can dissipate heat. So if your blood volume is low, just like if your radiator on your car is low, right, you're not going to be able to dissipate that heat, right? And you can't hold on to that heat. So they're going to have a low core body temperature, right? You can't hold on to it. And you have less blood circulating. So you got to keep these people warm, That's why if you ever watch movies, when they're bleeding, they start to shiver and shake because blood holds on to heat. If you're bleeding it into the curb, you're bleeding heat. Think of it that way. All right. Now look, one of the things that you're going to have to be able to differentiate is hypovolemic shock, and there's no signs of external bleeding. The first thing you suspect is, especially if someone comes into an ER and their blood pressure is low and there's no signs of external bleeding, right? One of the things you want to do is insert a Foley catheter and then drain the urine that's in the bladder initially, and then keep that catheter in. And then you want to start really large IVs and give them a fluid challenge, right? Now, again, you don't know if they're internally bleeding, but there's a way to check. Watch. You learn that the cardiovascular system is a circle. It's intact, right? So if you start big old IVs on somebody, right, and you give them a fluid challenge, what are you going to do? You're going to increase their blood volume. That is going to increase venous return, right? So the amount of venous blood coming back to the heart is going to go up. What is that going to do to the right heart? Well, that's going to increase the stretch of the right heart, right? And then that's going to increase the force of contraction, and that's going to increase your systolic blood pressure on the right side, and that's going to increase your stroke volume. So cardiac output will go up, right? So the amount of blood pumped by the right heart is the amount of blood pumped by the left heart. So if more blood is being pumped to the lungs, now more blood is going to come back to the left side. What are you going to do to the left side? You're going to stretch it, greater force of contraction. The amount of blood ejected with each beat, stroke volume goes up, and blood pressure goes up, and it goes up in your kidneys, right? And anytime you increase systolic blood pressure in your kidneys, that increases urine output. Urine output. So what do you want to do? You start the IV, you give them the fluid challenge. All of this stuff that I just explained to you will happen, and if you see an increase in their urine output, then you know that their cardiovascular system is intact. But if you're giving them a liter of fluid and you're not seeing an increase in cardiac output, then you know that that fluid and blood is going somewhere, and they are internally bleeding. So the fluid challenge is how they assess for internal bleeding. So you're going to be monitoring urine output and then monitoring their systolic blood pressure. Now, if their stroke volume goes up as you add volume, then their heart rate will drop, and that's because you got to maintain that cardiac output. So if more blood's getting pumped per beat, then your heart rate doesn't have to be clipping along as much. So that's the fluid challenge. Now, if they're bleeding their own blood, initially what you want is you want to give them IV fluids, but they're bleeding blood, and the best way to transport oxygen is bound to the iron on hemoglobin. So initially, you want to start big IVs and give them fluid, and then you want to give them a bunch of oxygen, because what you're going to learn, hopefully, is this, right? So what do? You stop the bleeding, and you should know the pressure points, the major pressure points in the body, right? Just a couple of things, right? If they have a big cut on their head, don't put a tourniquet around their neck. You're writing that down. Anyways, watch. Blood carries oxygen, and oxygen can be transported in two ways. Very important that you know this. One is it's dissolved in the plasma, and that's measured as a PO2, or the partial pressure of oxygen. Now, it's not the best way, but it is a way. So initially, when a person comes in and they're in hemorrhagic or hypovolemic shock, you want to give them volume. And then you want to give them supplemental oxygen because you just learned, or maybe you just relearned, that oxygen can be transported, dissolved in the plasma. So you pump up that blood volume and then you increase that FiO2, or the fraction of inspired oxygen, right? Room air is 21%. If they're bleeding their own blood, you give them 100% if you can. And then the best way, obviously, is bound to the iron on hemoglobin, but you just can't give any type of blood, right? You know that. So O negative is the universal donor. It's negative, O negative, because it's completely bald-headed. There's nothing on the surface of the red blood cell that that person's immune system can react to. That's why O negative blood is the universal donor. And you elevate their feet above their heart. Why? Uh-oh. Remember, where do you store a lot of extra venous blood? In your legs. Is there any pressure in your legs, in your veins? No. So what you do is you take advantage of gravity. So you put them on their heads. So by gravity, all of that venous blood that was stored sitting in their legs will now come back to the right heart. So in many hospitals, they have a little button that you push at their foot, and it raises their feet, so that Trendelenburg position, right? Putting them on their head, and that takes advantage of gravity and allows that extra venous blood that was stored in their legs to get back to their heart. All right? Now, again, the initial treatment is IV fluid rapidly, right? And you want to infuse it rapidly to try to increase their systolic blood pressure, right? And normal saline can be given, but sometimes they give what's called lactated ringers. Lactated ringers is basically an IV fluid solution that has the same concentration of electrolytes as normal plasma. So if you're bleeding your own blood, you're bleeding red blood cells and plasma. So until you can get O negative, or you can get the correct blood type to that person, then you want to give them some electrolytes as well. Also, you can give them colloid solution. So colloid solutions take advantage of the fact, colloid, big thing. So it's a big thing in your blood. And what that will do is that will draw fluid into the bloodstream by osmosis. So salt pork albumin, or dextran. Dextran is basically sugar from corn. So if you add more of that into the blood, then by osmosis, that's going to increase the blood volume. Usually, depending, that's done a little bit later, once you've established and kind of stabilized them with lactated ringers or normal saline. And also that colloid stuff is given for people who third space. So if they have a lot of swelling that you may see in like anaphylactic shock or septic shock due to the increased capillary permeability, you can use some of those colloid solutions to draw off that excess fluid. Now, the other labs that you want to check for are, you want to get the arterial blood gases, right? You want to look at the pH and their oxygenation, right? O2 sat and PO2, and then their PCO2 and their bicarbonate level. You also want to get lactate levels to see, remember that with the lack of oxygen, aerobic metabolism is not going to work that well. So anaerobic metabolism speeds up. Glucose to pyruvate, right? And if pyruvate can't get into the mitochondria to get Krebs out, then pyruvate gets converted to lactate, and lactate gets dumped into the blood, and lactate forms free-floating hydrogen ions, so it's lactic acid, right? So you want to see if they're at a point where they're producing lactate, and that means that they are lacking oxygen and they are still lacking blood flow. And the other thing is that you want to check their blood urea nitrogen and creatinine levels. And again, you want to assess kidney function here. Remember that when you drop blood flow and blood pressure, you drop oxygenation, and that can lead to end organ failure. So you want to make sure that your kidneys are being perfused, right? You're getting blood flow to your kidneys, because your kidneys can correct any pH imbalance if you live long enough, right? Now, just a couple of other things. In cases where you're giving them volume, but it just ain't getting their blood pressure up, then you can give some medications like that are vasoconstrictors, right? So you can give them epinephrine, adrenaline, norepinephrine, norepi. That's Levophed. You can give them dopamine or dobutamine. And these things are sympathomimetics. They mimic the sympathetic nervous system. But again, in the absence of any other problems other than the loss of blood volume, usually by fluid resuscitating them, giving them volume, they'll recover. All right, so I hope that helped a little bit. And then, again, if you want to understand the shock, make sure that you look at the stages of shock first, and then understand the cardiovascular system, circulation of blood through the heart, all that good stuff.